Yeah, so I'll start our introduction, Jeff, and then I'll let you finish it. So, is that okay?
Absolutely.
Yeah. So anyhow, every now and then you meet somebody and you're kind of starstruck. And uh, when I was in Miami in April, I had the opportunity of meeting Dr. Gelb, Dr. Martin, and Jen Kirkham, who were just three fascinating people, and always heard of the Gelb appliance, know how it's been utilized in dentistry, and never actually realized that I did actually get to shake the hands of the person that invented the appliance, and how much of a pioneer and a true asset to our profession he is. However, when you meet somebody like that, usually it's just kind of like, hey, how you doing? Get lost. Dr. Gelb took the time to get to know me. We had a very nice conversation, met with all of them. I was really honored. And over the past few months, I've seen that that's the kind of people that these people are. It's almost like they're Texans. I'm sorry. It is. It's just kind of the way that we roll down here. But he'd probably be really offended that I said that. Um, but anyhow, it's a real honor for me to have Dr. Gelb on our show. And Jeff, I'm going to let you do a more formal introduction, but the traction that we've had on this tonight has been fantastic, and I'm really looking forward to this.
So one thing that I have to say is many of you know the name Michael Gelb. And as I said in the introduction, Michael is a second generation innovator. So I actually got to study under his dad. And, most of you know my story that early in my career, when I was starting a practice, we only had one orthodontist, one pedodontist in the area. And that's kind of what got me motivated to learn orthodontics and to learn about airway and craniofacial development. And it's kind of what guided the rest of my career. So early in my career, we were doing a lot of functional appliances. They were very popular in the 90s. And there were people on the scene like Harold Gelb and John Witzig and just some great forward thinkers that were willing to take the challenge and go against the grain of dentistry and say, no, the best position for the condyle is not the most posterior superior position like we were all taught in dental school. We need to stop jamming people as far back as we can. And they really opened the door to this modern world, which we still have a long way to go. But fortunately, with pioneers like Dr. Michael Gelb, people like he and Lane and Jen and hopefully with some collaboration with other forward thinkers, we're going to really make this much more mainstream in dentistry, where we talk about correcting airways and correcting joint positions and correcting bites in the way that really it should have always been done, and in a way that this gentleman will tell you that it works. So as I said, he really needs no other introduction. He is an author. He is a speaker. He is an expert in the area of TMJ. I got to spend a day with him in his practice on Madison Avenue in New York. It was just, it was an absolutely incredible experience. He's authored the book GASP. I mean, I could just go on and on. Started the APMD. All of you out there who do any sleep know who this is. Michael, what an honor it is for you to join us tonight. So we really appreciate it.
Thanks, Jeff, Chad, Jennifer, it's great to be here with you guys tonight.
So why don't we start here?
It's our honor. Thank you for being here.
Thanks. Why don't we start here, Michael? So your dad, Harold Gelb, you're a dental student. It's got to be hard going through dental school when your father is Harold Gelb and your name is already marked. A lot of the people who wrote our textbooks already hate you because of your last name and
exactly
what your father stands for. So tell us a little bit about that journey and then your journey to where you are now in practice.
Yeah, I mean, it's a great question. No one's asked me that question before, but I'm at Columbia Dental School, and Joe Marbach, who's more into the hypochondriacal psychiatric approach, following Laszlo Schwartz, who was there in the 50s. And if you follow kind of the evolution of TMJ from Costin in 1934 with ENT ear symptoms with using a partial denture, Marbach says to me in the class, "What are you doing here in the class? There's no chiropractors here today." So that's how I was introduced. And then, when I was in the occlusion classes where they were trying to shove the jaw back, I had a really hard time. I had a hard time staying quiet. So I was not the most popular dental student. Did okay, pretty good with my hands, but just had to basically graduate from dental school. And then I went up to SUNY Buffalo, where they were just trying to disprove every concept. I got my master's up at Buffalo in a neuromuscular research program. And, so it was a little bit tough coming, growing up in dentistry in New York City, where the nephrologist, Frank Salenza, and Vinny was there. And I'm good friends with his son, Frank Jr. But, the nephrologist, the orthodontist really were shoving the jaw back, taking out bicuspids, and the prosthodontists were putting every case back in CR. And so, God forbid, I was on a phone call the other day, maybe about 3 years ago, and the guy says, "Do you screw up every case that you touch? I mean, do you screw up the bite in every case?" And I was like, "What? Are you talking to me?" And I guess that basically people dentists really don't understand that skulls have changed. Are you talking to me? And so, we can talk about how skulls have changed. I don't really think we're working on the same person today that we would have seen 200, 300, 400 years ago. So I think we have to start with that premise. If you've read, James Nestor's book, Breath, if you've looked at the work of Lieberman, Corricini, Weston Price, if you really understand how our skulls and how our bites have changed, if you understand that we don't have room for all 32 teeth, why kids sometimes need to get wisdom teeth out, I think we can maybe start with that premise.
It keeps muting him. Like he unmuted
muted?
himself. No, not you, Jeff. You unmuted yourself and then it muted.
There we go.
Okay.
I'm sorry. There was a little echo and I thought it might have been me, but it wasn't. So I muted my mic. But so for some of the people out there that may not be as well versed in TMJ and airway, what would be the reason to know more about the joint and about airway? Chad was talking about it a little bit tonight, that, a patient came in and, how often this happens, that someone comes in, they're like, yeah, I had apnea. I was told I had apnea, but, I don't wear my CPAP. I couldn't wear my CPAP. I'm not going to do it. Or even a lot of these bite cases that we happen to look at and say, you know what, this isn't just a bite problem. This isn't just a joint problem. There's also an airway problem, because these things really go hand in hand, don't they?
It's a great point. So, you have a lot of people in your practice, especially in the last 2 years with COVID. I mean, the rate of clenching's probably gone up by 300%. It's probably tripled. You've got more.
I think it's more than that.
Restorations, but more clenching, right? More jaw pain, more headaches, more wearing down on the teeth. And, we look at the airway as one of the potential factors or contributing factors to why patients also may be contributing more, clenching more, not just from COVID. So I think it behooves us. Only 15% of airway patients have been diagnosed, officially diagnosed. So these people that are coming in with CPAPs and they don't want to wear CPAPs, you're talking about 15%. Just imagine that every day in your hygiene chair, every day, Jennifer and Chad, Jeff, Jeff knows this, but every day in a general practice, 50% of the patients in your hygiene chair are either tired, they're exhausted, or they could be more refreshed. And remember, I always say men are in denial, and women speak in code. So if you ask a guy, do you have a problem? I don't have a problem. It's my wife's problem. She snores. I don't snore. She snores. So, first of all, people don't admit, no one comes in and they say, I have an airway problem. People
Yeah.
don't know that they have a problem breathing. People don't know. And so Jeff and I were talking, we believe every dentist in the United States should have a cone beam. 100%, I 100% believe that the standard of care is cone beam. So Chad, for a patient to come in that's on CPAP to say, I'm not going to do that CPAP, patients require a lot more education because they don't realize that how they breathe is probably as important or more important than what they eat and how much they exercise and about their mental attitude. They just don't understand that. And they don't understand that our airways are getting smaller and smaller with every generation. And that our airways today, for at least half the patients in the chair, our airways today are really not able to sustain a healthy lifestyle or really a healthy way of being.
Well, let's take it a step further too. We had this conversation how many times in the patients that we saw that day about orthodontics that unfortunately is still being taught where we're making the arches smaller and these people are already just through evolution already ending up with smaller airways, and then we're doing even worse. We're constricting the arches in some cases with extractions and talking about reductive procedures and closing bites down sometimes with equilibration. And so it really has an impact on all of the dentistry we do. It's not just its own world. Airway is not its own entity. It really needs to be a part of all the dentistry out there. And I was so impressed. We actually met two young ladies that neither one would really be considered to be severely apneic or even moderately apneic by most pulmonologist or ENT or sleep physician standards, yet they were suffering from an enormous amount of sleep disturbance, which affected their pain threshold and affected a lot of their anxiety levels and their everyday function. So, Michael, I'm just so thankful for that experience because it really solidified what we believe, and to see you carrying that out and doing it in a way. I asked you, how do your patients come in? I don't know if you remember me asking you that question at dinner. I said, are your patients mostly coming in as a TMJ consult? Are they mostly coming in as a sleep consult, or how are they coming in? And my question was answered the next day when every patient pretty much had the same workup, because we need to consider all of those factors in every single case. So thank you for that. I thought it was amazing.
No, it's a great point. I think we've come to the fact after 200 to 300 years, I think we've come almost to a breaking point, because with weight gain, it's bad enough that our faces are getting, I've got a narrow face. Our airways are getting smaller and smaller. Our jaws are shrinking. And yet we keep doing retractive Nightguards and we keep doing retractive orthodontics. And so the fact that our faces are naturally, everything was bad enough to begin with, but then dentistry has been a retractive profession. And we're supposed to have taken a Hippocratic oath to do no harm. And yet dentistry every night closes the airway in, I think, 50 to 90% of cases. And our orthodontics with interproximal retraction, IPR, we're a retractive profession orthodontically as well. And so if you add those two things together, it's not a very good scenario that we have today. And it's time. I consider it a Harvey Weinstein moment now in dentistry, that it's time that we do no harm. It's time that we don't close. Like from tonight going forward, I think do not close the airway. Don't take out that bicuspid. I think everyone's on notice, from the oral surgeon that takes out the bicuspid to the orthodontist that orders the extraction of the bicuspid to the mechanics that pulls the maxilla back. You are on notice right now, as of tonight, for this Dings podcast, that this is the time, this is the line in the sand. It's no longer acceptable for Harvey Weinstein, for sexual harassment. It's no longer acceptable to close the airway in dentistry.
So
I was wondering where you were going with that. I was
so-
he will say something worse than me.
Dr.
Well,
Gelb,
I was trying to, but
it's so great that you say that, because I find myself and I look at my brother who's 9 years older than me, and I look at my wife who had all of her buys extracted, and I see people in my practice on a daily basis, and I find that I'm making excuses for the orthodontics that was performed in the 70s, 80s, 90s, and all of these extractions. And you're seeing all of the we're seeing all of the problems now. And what was created by this. And you sit there and you scratch your head, because you never want to throw somebody under the bus. But deep down inside, we all know what we're thinking. We're like, oh my God, what were they thinking? And I've told patients, I will not extract these buys. There's no way in hell. I won't do it. I'd rather you get a second opinion than me extract these buys, or me even sign a referral to have the buys extracted.
no,
Is
totally
that wrong?
agree. So I think that the problem is, when Howie and I formed the nonprofit, the APMD and the Foundation of Airway Health, we were getting tired of seeing 50% of our patients had their buys extracted or had retractive mechanics. Bill Hang found the same thing. John Mew finds the same thing. Dwayne Grummins, Barry Raphael, Victor Avis. There's countless orthodontists around the country that have seen this. They're so guilty over the bicuspids they've extracted. The crime is the orthodontic programs around the country and the American Board of Orthodontics that still requires bicuspids to be extracted. The fact that we're continuing to mutilate the dentition, the fact that we're continuing to teach this in our programs, how can we eradicate it if dentists are coming out of schools having been taught this, and it's still continuing today? So I'm glad that I'm on here, that I can share this. We're here just to make everyone healthier. We're here to make dentistry about healthier patients. We're looking at the individual that's attached to the teeth. And I think we're, the four of us are on the same wavelength, right, as far as that goes.
I'd like to ask you, since we're in the topic of orthodontics, because we know that we treat pretty early these days. And, I've seen in my own practice that particularly in boys, that treatment may have been too early. There was too much retraction that was done. And then they get a late mandibular growth shift forward, and they either bust through those upper incisors, or they start to develop TMJ issues, or some combination. And my question is it time as a profession to look at staging orthodontics in a different way? I mean, when I was in dental school, which I'm 14 years out, it was all about treating during pre-puberty and prepubescent. That was the time to sort of capitalize on the growth development curve and then treat orthodontically within that space. And as I've been in private practice and seen some of the long-term ramifications of that decision, it's now come up as a topic with myself and my business partner of, is this really still fundamentally sound? Is it biologically sound? Is this still the right methodology? Has it changed? And any insight into that would be fantastic.
Yeah, I have a lot of opinions upon that. So the orthodontist finally came that they should intervene possibly at age 7. And the ADA just came out with the fact that you should look for airway and sleep problems in kids, and you should refer out appropriately. Now, what we're saying and what Kevin Boyd is saying, and we're saying, you want to intervene under age 5. If you wait till age 11, 12, 13, if you wait for the permanent dentition to be in, orthodontics and pediatric dentistry is primarily about brain development. We can get 50% of kids off of ADHD meds. Kids are born with anxiety today. Kids are born as mouth breathers. In the appropriate settings, we're advocating getting in as early as 2.5 years of age, 2 years of age, 2.5, 3. The crime that's happened is that we wait until, of course, the mouths are crowded. The crowded teeth are the symptom. They're not the cause. They're not the problem.
Right.
So now you tell the mother of a 12-year-old, the teeth are crowded, we don't have room. And of course we say you can't, the suture is fused. You can't expand the suture, which of course is a lie. The problem with dentistry and the way orthodontics is taught today, it's based on dogma. It's not based on science. And so if you have a kid at risk, I want to get every kid in pre-K mainstream into a normal classroom, in whatever normal means. I want all the kids to be together. I think if the kid can't focus, if they have ADHD, I want that kid's airway treated. I want the tonsils and adenoids treated. I want the maxilla expanded. I want myofunctional therapy. By age 4, I want them treated. The latest age 5 or 6. By the time they hit pre-K or kindergarten, I want them to be able to have a good night's sleep. I want them to be refreshed. I want them to have good energy during the day and not to be on any ADD meds. That's my goal. So that means that 50% of the kids have to be treated before age 5, less than 5. That's the movement today. That's the Endeavor movement. That's what Steve Carstensen, Barry Raphael, Susan Maples, Bill Hang, Lauren Bollinger, that's what they're trying to have all the dentists do, is to intervene early. So age 7 is too late. So the orthodontists have really begged the question, and don't be afraid, 85% of all maxillas are retruded. So what you said earlier, JB, I don't see any kids that are busting through those maxillary teeth. The maxilla has to be developed at a very early age. Most maxillas today are underdeveloped, and that needs to be changed at an early age.
He muted himself again.
Jeff's talking. Jeff's like,
Jeff doesn't need his words.
Yeah, I got my hands.
Use your words, Jeff. Use your words.
It's all about the hands. I kept hearing echo, and I keep muting my mic, thinking it might be me, but we have a little bit of echo tonight. So one of the things that I will say as well is that in the orthodontic world, it's not just about the 4 bicuspid thing and the airway thing, as we all know, and where your dad started was in TMD and temporomandibular joint problems, and how many cases we see where the teeth are corrected to a pathological joint position. And this is yet another problem, because number one, that will make an airway problem, or not help the airway problem. A retruded mandible means a retruded tongue. A retruded tongue means a compromised airway. But also, we have witnessed education in the orthodontic world where teeth are correcting a malpositioned joint or a disc that is out of place. And instead of correcting the patient orthopedically, we are correcting them dentally. And guess what? That's not where we needed to be all of these years. And it is not a sin to change a bite, to change a profile, to change B point. These are all positive changes, and you can speak to it because you've done it even longer than I have, and how many positive outcomes we've seen both in airway and in myofascial pain symptoms when we do change orthopedically versus dentally. Would you comment to that?
100% correct. I'd say that 90+% of the orthodontists pay no attention to the TMJ. They don't look at cone beams. They don't pay attention to condylar health, condylar position, disc displacement, and maybe they're still following the dogma. Maybe they still think we're in 1980 before Dawson changed the definition of centric relation. I think most of them think we're still in rearmost, uppermost, or they don't care. And they certainly don't look at the airway. So once they ignore the TMJ and the airway, they're basically just tooth aligners. And so it's unfortunate that the general dentists really do a much better job orthodontically and orthopedically than any orthodontist out there. And there are few exceptions to the rule. There are the Dwayne Grummans that are great. There are the Bill Hangs that are great. My friend from West Virginia, and the neuromuscular orthodontist that's teaching great. You took some great lectures from USDI. you know, there are good orthodontists out there, but too many people are pulling that maxilla back, not realizing, and it's immutable. So Charlie Green talks about irreversible treatment. Well, if the jaws are in the wrong position and the airway's too small, you have to move teeth, you have to expand, you have to resolve the problem. And fortunately, orthodontics is probably the best way to fix the problem. It's the way that we're resolving the problem in adults, but we don't see it happening. The orthodontist could be the superhero. Unfortunately, the general dentist is really forced into being the superhero in dentistry. And so we'd love to get the orthodontist on board, but we've kind of given up on the orthodontist. The pediatric dentist is making too much money filling teeth. So we're trying to get the pediatric dentist to wake up and realize that it's about the health and wellness of the kid, and that it sets the stage. What you do at age 2, age 3, age 4, age 5 is really going to determine the health of the next 20, 25 years. Otherwise, we have to clean everything up at age 35, 40, 45, 50, where we then have to do the expansion anyway, because it's apparent that they can't breathe. They're anxious, they're depressed. Everyone's on Lexapro, everyone's on Wellbutrin, everyone's on omeprazole. They have hypertension, they're exhausted, everyone wants to be more refreshed. And so we've got to clean up the situation as adults. We're trying to put ourselves out of business, but they're making us busier and busier. Like my dad said, you can't help but be successful doing TMJ and airway because not only of the epigenetic factors, but of all the dentists that just keep screwing things up in the early years of a patient's life.
So I absolutely love what you said, because I'm just going to go ahead and admit, due to state laws and what we're allowed to do here, I'm probably the least versed in sleep dentistry, but I've started to, after hanging out with this knucklehead over here, I've started to learn a lot more, and I've started to really notice the problems that my patients are going through, and I'm starting to seek help for them. And so in doing so, I think the first thing that I realize is that where we need to start is orthodontics. There's so many orthodontists that really need this help. So I spoke with a couple of orthodontists in my community, and there's one that I just said, hey, let's join this venture together. Let's really immerse ourselves and start learning this and figuring out how we can help people. And he was like, I'm all in. Then I had this patient that came in, young lady, 16 years old, lots of sleep related issues, definitely retrognathic. And she was referred by another person, I will say, but she found an orthodontist, and just by happenstance, I found this gentleman, and he happened to know a lot about sleep and was starting to talk about what he can do with this young lady. And so I'm seeing some of the younger orthodontists that have some experience with this, but I think that all orthodontists need to have experience with this. And I think we need to start that trend, and that we start bringing this into orthodontics. And that's kind of what you're doing, isn't it, Dr. Gelb? You and Dr. Martin and Jen Kirkham, isn't that kind of what you're doing? Ortho?
Well, we've started, Lane is part of an orthodontic program in Hoboken with Dr. Alicani called CTOR Academy, where it's probably the first airway positive, airway focused orthodontic program, pro airway, in the country. So they have molecular biology, they have the methodology in adults to be able to expand the airway. And, it's being done. So we're still hearing from people around the country that it can't be done. Dr. Alicani has the research first on rats and now in humans, and they're getting 2, 3, 4, 5 millimeters of expansion in adults, not tipping teeth, but actually growing bone and expanding the palate and making the more room for the tongue. So yeah, Chad, I love it. I love orthodontists are the superheroes, but I want them not to be the supervillains. I really want them to step up into their proper role, is to be the superheroes.
It's not their fault, is it? I mean, a lot of it is the training that they get in their programs, and it's almost an indoctrination into the dogma that you speak of, and these even going back to the 7 keys to occlusion, and one of them is no spaces. I'm like, are you kidding me? No spaces at the end of treatment?
Yeah.
I mean, that's half of our problem is to close the spaces. What are we doing? We're pulling everybody back. And if you do that, especially after bicuspid extraction, you've got this excess space. When we pull people back, we're taking away tongue space. We're taking away arch development. So,
well, that's why people like Ben Moralia and Lauren Geitz, Airway Health Solutions, and people like Lane Martin and CTOR, you basically are going to have to take all the faculty members that are at these, they're so indoctrinated in these earlier mechanics, they have to be retrained at Myrtle Beach and your academy. They have to be retrained by Ben Moralia, by people like Lane Martin, because they don't know how to do it. They have never learned. So the faculty members at all these ortho programs don't really know how to expand the airway. They don't think it's possible. And they're stuck in tweed mechanics, and they're stuck in the type of mechanics that they were taught by their instructors who were shutting the airway. So I say the time is now to stop these programs. Maybe you need to suspend them, put them on hold until the faculty can get retrained. But that's not a bad idea. That maybe is what we need to do in this country, is just to put all those ortho programs on hold or stop them from doing any mechanics that may potentially close the airway.
And I would say spacing is beautiful.
Spacing
I'm going to go out on a limb.
Look at Lauren Hutton. Look at David Letterman. I mean, space is beautiful.
So how do we get the medical community on board as well? Because I continue to struggle when I see kids that come into the practice that have very constricted airway. They're presenting with medical issues that would suggest that we may have a sleep-related issue. And you look back there and it's, this very thin, narrow piece of space and then these large tonsils. And then you send them off to a medical evaluation with their pediatrician and the ENT, and they come back to you 6 months later, tonsils are still there, almost touching. And the response was, well, they weren't touching, so we didn't take them out. And, so to me, then it's super frustrating as a clinician too. Like we, as a dental community, we can get all on the same page. That would be a phenomenal advancement in our profession. But then we still are reliant on another profession to also get on the same page. And I find I run into that wall quite frequently, actually.
Yeah. So here's what you need to do, JB. I'm 65. My life is too short. I'm not going to wait and train people. I'm not going to do like Kevin Boyd does and call up the pediatrician. And so I would say that it's the 80-20 rule, JB. 20% of the ENTs in your community get it, 80% don't.
Yeah.
Just sidetrack the pediatrician, send to the pediatric ENT that understands. So they're either going to take a plastics they either go in a plastics route or they go in an airway route. So find some of the pediatric ENTs that have been trained in airway. They'll understand the role of airway and how it relates to ADD. They'll know it in 2 seconds. You don't need a sleep test. The insurance will approve the removal based on obstruction, not based on infection.
Right.
So you will find 1 to 2 ENTs in every community. Jeff, it's harder in Myrtle Beach and Pawleys Island, but we just need 1 ENT that we can refer to that gets it, and they'll get it done. And they may have to go into Charleston. They may have to travel 20 or 30 minutes. But I'm telling you, 80% of the ENTs out there, they're going to say, let's just watch it. They're not, they're not totally blocked. You're not dead yet. So, let's just watch it. You're going to die slowly, so they won't pin it on me. It's the same thing that the dentist does.
Right.
You got to get the kid as soon as possible, especially if they have prefrontal cortex issues, if they have speech issues, if they have sensory integration issues, if they're a kid that's at risk with learning disabilities, anxiety, depression, peer-to-peer issues, withdrawal, teen suicide. If the kid doesn't feel good and they have a narrowed airway, you cannot stand by and listen to some ENT that doesn't know what the hell they're talking about.
Yeah.
You find the ENT that does, and you can find it within an hour of where you are. Go to the AAPMD website and see someone who's taken the airway pledge. It's free. So we need a grouping, like a group like the AAPMD, where everyone can join. The physician can join with the speech language pathologist, with the dentist, with the pediatric, with the general dentist, with the orthodontist, and the people that believe in airway. The public can go online and find those people.
I love that.
That's what we need.
That's awesome, because I think we all need help in finding resources in our community, and also not being afraid, feeling confident and empowered to continue to push our patients to find the right avenue.
Yeah, please keep pushing. Don't give up, and you're doing the right thing.
So I have a question.
I just want to take an aside here, because we've spent all this time talking about airway, and I think we beat up a little bit on the orthodontist, but I think there's a lot of progressive orthodontists out there. There's a lot of good orthodontic training programs like what Lane Martin is doing, and some great programs out there. But I want to talk for a minute about even your interpretation of what a night guard should be. So a patient who is clenching, you're actually incorporating airway into occlusal guard therapy, which, you know, for anyone who knows any of the research and data on airway, is that we know that if a traditional night guard is made for a patient that has steep incisal guidance that locks a patient back, that we, for 50% of the people with apnea, will actually make their apnea worse. And you've kind of taken a step with some of your appliances and your dual therapy to change the way we think about bruxism and night guards. Will you just speak to that for a minute? Because I think this is interesting.
Right. So when we were in dental school, we were taught to make the night guards in centric relation. And that was just backed up by Pankey and Dawson and Spear and Coyce. And so most of the night guards in this country, at least 90% of the night guards that I see, the research says it's 50%, but I think it's closer to 90. Most of those night guards are made just by flat plane appliances, cuspid guidance. They open up the vertical, but like Lane Martin will say, when you just open up the vertical, Posselt's envelope of motion, as the jaw comes back down, it's going to close the airway. So you're doing exactly what you learned. You can pass the boards. You get an A in your exam. But you know what? You're striking out because you're closing the airway. And we took a Hippocratic oath not to do that. So what the American College of Prosthodontics said, you've got to introduce a small amount of protrusion into the night guard. You've got to open the airway and not close the airway. So Lane and I have come up with Jen Kirkham with GPS. We actually are coming up with a night guard that's a day appliance. It's like a lower full coverage appliance. So it's your day workplace sleep appliance. So you can use it for work, you can use it for play, but when you combine it with an upper appliance at night that puts a small amount of protrusion in with some elastics, you actually have a night guard that opens the airway, allows you to awaken more refreshed, in a better mood, with no snoring and less clicking and popping and less clenching. So it's a total departure from the night guard, your daddy's night guard, or the old fashioned, I call it the primitive night guard. I'll be talking about it at the Hidman meeting, but it's something that's very easy. It's just as easy to make a night guard that doesn't close the airway as it is to make a night guard that 100%. Opens the airway.
And also, we always encourage, because again, for those that aren't doing a lot of sleep at this point, we know bruxism, although all bruxism does not mean sleep apnea. We know that a lot of bruxers, you know, it is very often seen with sleep apnea. And I think we owe it to our patients to at least rule it out before we make any type of a flat plane splint or bruxism appliance that could potentially make the patient worse.
Beautifully said. So that's what the American College of Prosthodontics recommends. Get a sleep test done. We're advocating sleep tests in up to 50 to 90% of your hygiene patients. So if you see wear of the teeth, if you see abfraction lesions, recession, broken restorations, please get a sleep test and then make a night guard that does not close the airway, or refer out to someone like Jeff that treats sleep disordered breathing that can make an FDA approved device. Well said, Jeff.
I thank you. I can't believe how quickly this hour went by, but we are at 9:29 right now. We are going to have a part 2 if you will agree to it.
Yeah, we'll get Lane back. Can we get Lane back next time?
Absolutely. And for all of you out there, Dr. Lane Martin, who is also a Coyce grad, has worked with Dr. Gelb and Dr. Kirkham and has really been very inspirational to me and in what's possible out there for the future of dentistry. He was supposed to be on the program with us. He's actually spending some time working in Dr. Gelb's office, but I think he has a birthday either today or somewhere right around this area. And he had some other plans tonight, couldn't make it. We missed him, but we will definitely get you back with Lane. Love to have Jen on as well. And, you know, I have to say what a pleasure it was being with you for 2 days. I'm going to teach everyone a new Yiddish word tonight. This is Yiddish 101. They learned mishpucha. Now they're going to learn mensch. That's what you truly are.
I already knew mensch. We all knew mensch, Jeff, and we knew that Dr. Gelb was a mensch.
Yeah. Okay.
Yeah. Thank you, Chad. Thank you, JB.
Yeah, I had told you that a long time ago. But you know what? I want to have you. I want to have Lane. I want to have Jen. I want to have the whole round table, and I would love to have a lot of audience participation. So
that'd be great. That'd be terrific. Thank you so much.
Thank you so much. It was so fantastic.
Same here.
Yeah.
Thank you.
Thanks, Michael.
Thanks, guys.
Okay. Have a great night.
You too.
All right.